thank everyone for coming to this CME. So I would like to introduce our team of doctors. So Dr. Rahul Narayan, medical oncologist. Dr. Hazrat, he is the surgical gastroenterologist. Dr. Abhinay, medical gastroenterologist. And Dr. Abhinav, head and neck surgeon. And we have one more surgical oncologist, Dr. Vinith, he did not come. So the main motto of the hospital is to be a full-fledged multidisciplinary hospital, facilities in the department of oncology and gastroenterology. So I thank our Chikkur population. The population is from the districts of Warangal, Karimnagar, Khammam, and also the 10 down districts of Chhattisgarh and Maharashtra. Because in Chhattisgarh and Maharashtra, cancer facilities are very poor. When you see Chhattisgarh, you have a cancer hospital round about in Raipur. So 10 districts of Chhattisgarh, they don't have proper cancer facility. So we have created the hospital on the highway so that it would be very near to the Chhattisgarh. So future we would like to start DNB and MCH programs, especially in surgical oncology, head and neck surgery, and medical oncology. Few patients with pre-malignant lesions where we do not know what is it. When we use this narrowband imaging, would and we have this microscope to the last terminally ill patients. So hospice is first of its kind. And we have a healing garden. So it's going on in the construction process. So the facilities, we have organ-specific clinics, radiation oncology, surgical oncology, medical oncology, pediatric oncology, hematology, and oncopathology, head and neck surgery especially. So we are doing all sort of oncology reconstructions, right from the head and neck, and even limb preserving surgeries also we are doing it. So head and neck oncology services we have started, and we have a in-house full-time surgical oncology team, and we have a head and neck surgeon, Mr. Abhinav. So we have started doing the case also. So I think we have done around about 150 case surgeries we have done, and around about 2,500 OPDs we have seen for the past 6 months. So head and neck oncology services, Abhinav will speak in some time. So we do all the surgeries: thyroid, neck, salivary gland, skin, benign tumors, and laryngeal. So this is the LINAC, which is a high-end linear accelerator, which is equipped with SRS and SBRT, which means stereotactic radiosurgery, which is nothing but the gamma knife. So this is also first of kind in Warangal. Acoustic neuroma. So he was around about 80-85 years old. He was not fit for surgery. So we have given SRS. The treatment was completed within 5 days. And the patient was discharged well. So we have this brachytherapy facilities also. Brachytherapy, where you give brachytherapy in regular in case of carcinoma of the cervix. Brachytherapy is not available elsewhere in Warangal. And this is an advanced PET-CT. This PET-CT is first of its kind in Warangal. You have one more machine at Hyderabad AAG. This is Siemens time of flight technology, where the dose we give to the patient is very less. And we do very quick PET-CT. Maybe in 10-15 minutes we do a PET-CT. So in one day, we can do around about 30 to 35 PET-CTs also. So recently we have done 18 PET-CTs one day. So the preciseness is very, very accurate. And in comparison to the other PET-CTs, the GE machines, this Siemens time of flight technology is most advanced. And we have a full-time nuclear medicine department also, where we are starting FAPI scan also, maybe in 2 or 3 months, where we have a gallium generator, and there we don't need to give an appointment to the patient because you have to get the source from Hyderabad. So we have this digital mammogram with the stereotactic biopsy facility. So this is also first of its kind. And medical oncology and hemato-oncology, Dr. Rahul, he has been practicing for the past 10 years. He has shifted from Karimnagar to Warangal. So we have started Arogistry in the month of January. So all poor, unaffordable patients, no patient is sent back, even head and neck, everything we are doing under Arogistry. And the next presentation would be by Dr. Abhinav.
Respected all, I am Dr. Abhinav, Head Neck Oncosurgeon at Prathima Cancer Institute, and I would like to thank AOI Warangal branch for giving this opportunity to speak on this evening. And it would be an honor to speak in front of all my senior professors and my senior colleagues and my friends as well. Before going to the today's presentation, I would like to present the scope of surgeries that we are doing at Prathima Cancer Institute in all scope of, I mean, head neck cases that we are doing. So far in the last 2.5 months, we have operated cases of nose and PNS, lip and oral cavity, and head neck endocrine surgery. Like, very few cases that I would like to show that we have done. This is a case of 75 years old female with a BCC of nose. We have done a wide excision with a paramedian forehead flap reconstruction. And this is a case of CA maxilla. And we have done a infrastructure maxillectomy with a palatal flap rotation and a buccal pad of fat reconstruction for closing the oroantral fistula and with neck dissection. And we've done cases of oral cavity right from T1 lesions to T4B lesions as well. And this is a simple case of T1 lip with wide excision, a wedge resection with a mucosal advancement. And this is a case of a soft tissue sarcoma of the left floor of mouth. We have done a marginal mandibulectomy with wide local excision of the floor of mouth with pedicle nasolabial flap reconstruction and selective neck dissection. Biopsy of the right submandibular region, but it turned out to be a SCC of the, it's a secondary deposit in the neck that was misdiagnosed. And later on, we had to do a wide excision of the level 1B skin along with the right MRND. Been doing early thyroid malignancies as well as advanced thyroid malignancies. This is a huge T3 lesion with a huge neck metastasis. So we do a total thyroidectomy with central compartment neck dissection and left MND. And I would like to present an interesting case that we have seen in the last month. This is a case of a multinodular goiter along with a cyst on the left side of the thyroid that was extending from the skull base till the arch of aorta, and it was diagnosed as a Bethesda 2 lesion on FNAC, and ultrasound and CT was also suggestive of a colloid cyst with multinodular goiter. So we had done a total thyroidectomy along with the cyst excision, but the cyst turned out to be a non-functional parathyroid adenoma. It was a cystic parathyroid adenoma. So this was the cyst, and later on we have done total thyroid also for this case. So coming to the today's topic, changing trends in the head neck cancer. So I would be presenting my presentation in the following headings: the epidemiology, changes in the epidemiology, diagnostics, as well as treatment and rehabilitation. So intentionally, I put up this slide of epidemiology because this shows the actual burden of the head neck cancers in India. So if you could see the India map is marked dark blue, it suggests that it is one of the highest more burden of head neck cases all over the world. It's 16.7 to 17 per 1 lakh population. And this is the trend of the So this is how the head neck malignancies have been so far from 1980. This is the data from WHO data of 2020. If you could see various malignancies of head neck, one is lip, larynx, thyroid, and based on the males and females, if you could see that it is on the increasing trend from the past 2 decades. So I would like to bring a kind notice that if you could see in the next 20 years, you could see almost a rapid increase of 57% in headache malignancies in the India. And even if you could see the death rates as well, it is going to increase by 60% in the coming 20 years. One interesting slide is that there will be an epidemic of oropharyngeal malignancies in the next 2 decades. You could see that 64.3% and 67% increase in the rates of oropharyngeal malignancies. So, as we all know, the current etiological factors like smoking, and smokeless tobacco or alcohol. There are some new factors that are emerging as a causes of head neck malignancy. One is the main thing, that is HPV related malignancies. So now, in the last 2 decades, West has seen an epidemic of rise in the oropharyngeal malignancies related to HPV. That trend, we might see the similar kind of cases in the coming next 2 decades. Coming up in a high way in the treatment of head neck malignancies. See, this is a concept of radiomics and radiogenomics. You actually acquire an image of the patient, that is either CCT or a MR, and you correlate or put it into a computer model along with its clinico-pathological variables. So, coming to the pathology that we are doing, routine histopathology is the gold standard as of now, but still, we are moving beyond the routine histopathology. Machine learning technology, app will be developed so that through the app you can actually screen a malignancy. It's a non-invasive modality, and this will take. It is in a very primitive stage. It will take another 10 years or 20 years maybe to come up. So, as I was previously talking, the current era of head neck cancer treatment is not a single person treatment anymore. You are a clinician sitting in a hospital, patient is coming to you, you can cut and send the patient, but that is not going to be the treatment anymore, because the world has moved. There are studies in US and UK where they've told that DMG based treatment, that is disease management group, particularly for particular type of cancer, like suppose GI cancer based DMGs and head neck cancer based DMGs, the patients treated under DMGs had a better survival comparative to the patients those who are treated by an individual doctor. So it is more towards DMGs now. So actually, a well-functioning DMG should have a surgeon, a radiation oncologist, a medical oncologist, a pathologist, one radiologist, and a social support, social worker, and a physiotherapist along with that. So a well-formed disease management group is very much important in treating these kind of patients. On surgical treatment, what are the advances that we are currently seeing, and what is the future? So one thing that we are doing is right now the sentinel lymph node, the routine neck dissection. Instead of routine neck dissection, we can go for a sentinel lymph node biopsy. That is, you give a radionuclide nucleate dye, and you select a node that is a precise node, and you try to bring out that node, see whether there is a malignancy in that node. If there is no malignancy, then you can skip a neck dissection. So the quality of life in that kind of patients are good. Virtual surgical planning, you plan the surgery on the CT. I mean, where exactly you want to give a cut on the mandible, where exactly you want to give a cut on the maxilla, and you try to develop a model for reconstruction as well, so that the outcome of the patient post resection and reconstruction will be an ideal. And as you know, the other new things that is the minimally invasive surgery in head neck cancers. One is the robot based resections, that is robot assisted oropharyngeal and supraglottic malignancies, or robot assisted thyroid surgeries or neck surgeries. And another latest technique is minimally invasive surgery in the laryngeal malignancies. Routinely, we do a microscopic microlaryngeal surgeries. Now, this is something called as exoscope assisted microlaryngeal surgeries, where you don't have to see through the microscope and operate. Somehow, there is a scope. You project it onto the patient, and it will show up everything on the screen, and you can directly operate. So it is more convenient than the your microlaryngeal surgeries. So so these are the current trends that are changing trends in the head neck malignancy. It's a very broad topic. I tried to concise it, and I would like to thank everyone for giving this opportunity.
Thank you, Abhinav. Then a small presentation from our radiation oncologist, Dr. Vishnu.
Good evening, everybody. I am Dr. Vishnuvardhan Reddy. I am a consultant radiation oncologist, Prathima Cancer Institute. Um, Today we have a short session regarding radiation treatment, what we have doing in our hospital. This is our Electa machine, Electa Infinity. We can do SRS and SBRT also on this machine. So Electa Infinity is equipped with the Agility MLC. It can capable of doing SBRT, SRS, IGRT, VMAT, 3D CRT and IMRTs. This is a flexitron brachytherapy equipment. We can do brachytherapy in head and neck cases, gynecology cases. And this is a case of CA tongue with a conventional radiation. We can spare both the parotids and the oral cavity considerably and mandible also. So treatment effectiveness will be improved and quality of life will be improved. This is a case of carcinoma buccal mucosa, carcinoma of soft palate. And lastly, this is a first of treatment in Warangal and this part of the Telangana, stereotactic radiosurgery, which is possible in our Prathima Cancer Institute. So vestibular schwannoma, the lesion size is less than 3 centimeters. So we can see the dose distribution. High amount of dose can be delivered in a short period of time. Treatment was completed within 5 days and the patient is doing well. The lesion is closed. Thank you.
Thank you, Vishnu. So, any seniors like to speak?
Thank you, Prathima Cancer Institute. It's a very the presentation you guys gave us was fantastic. I think it's it's a dream come true for Warangal to have such a wonderful hospital, cancer hospital coming up in. A big applause to the team and management and everybody who was associated with the Prathima Cancer. And AOI Warangal, as a secretary, we'll always be there with you. We have been there with you and we'll always be there with you. Thank you very much.
Good evening, everybody. Thank you, Abhinav, for your excellent and elaborate lecture. And he is our man. Our man means MSCNT. That is important. Who is those who have MSCNT? They do well in head and neck surgery. Take my words.